He had to show me how to do it because I'm a colorectal surgeon. I'm not a neurosurgeon, so thank you very much. So thank you very much for the invitation. This is a subject that's actually quite interesting to me. These are my disclosures. So for rectal cancer surgery, we were not very good at this until about 1982. In 1982, Dr. Heald presented his original paper on TME, and this dramatically changed the perception of how to do rectal cancer surgery. And I put up here their article from 1986 with their follow-up. And when you compare it to what was going on in the rest of the world with 25 to 50% local recurrence rates and with 50% 5-year survivals, these numbers really got the attention of the entire colorectal community. And he described, and I put in quotes at the bottom of the paper, here's how I do it. I don't just shove my hand down there and bluntly dissect. It's meticulous, sharp dissection in this new TME plane that he described. And when I say the world took notice, what happened over the next couple of years is countries like Sweden and the Netherlands and Norwegia, which I think is also called Norway, they basically took this information and they said, we're gonna use video, and this was one of the first times this was done. They took video of Dr. Heald's surgery and they taught their surgeons. They videoed their surgeons and sent them back to Dr. Heald and his team and used this to train surgeons and to monitor quality of TME. And through this, you can see they had dramatic improvement. APR rates dropped in these countries, local recurrence rates dropped dramatically, and 5-year survival increased. So open TME became the standard of care and was taught all throughout. And when I was in training back in the 90s, this is how I was taught. But unfortunately or fortunately, there was something else going on in the surgical world, and that was the development of laparoscopic colectomy with the first procedure in 1991. And it grew in popularity, mostly in benign disease in the 1990s, but there was a question whether laparoscopic colon surgery was safe for cancer. And in 2002 and 4 and 9, studies came out, and we found, yes, it was not inferior, and so laparoscopic colon surgery was now considered acceptable for colon cancer. Well, what about rectal cancer? It's not that different, it's just a little further down the road, right? Well, it turned out it was pretty different, and in particularly the classic trial and the ACOSOG trial, as well as the Alucard trial, there were real questions raised about how lap TME was being performed by many surgeons throughout the world, and perhaps the quality was not as good as it should have been. And in 2015, there was a lot of drama in the colorectal community when these papers were presented that basically questioned all the lap TME that was going on out there. And so why is it so different? And I put the picture up there of the chopsticks versus a spoon trying to eat soup. Lap TME, you probably need to do a lot of lap and a lot of TME before you try and do lap TME. And there are plenty of studies using QSIM or RA-QSIM analysis that show perhaps 50 to 100 cases are needed. Well, what happens to those 50 to 100 patients while you're learning? They don't do so well sometimes. Their circumferential margins may be positive more often. They may often have incomplete mesorectal excisions, and as a result, they may have shorter or worse outcomes as far as 5-year survival. We also learned from many authors that conversions were not benign. 20 to 30% of these cases were being converted, and those lap converted to open cases often did the worst of all the groups. But we now had laparoscopy, and as you learned if you were at the session this morning and our previous speaker, now we could record all these cases because they were being done laparoscopically and not open. So people started to think, well, let's record the cases, let's review the cases with some kind of scorecard or competency assessment tool, and then let's give the feedback to the surgeons. This was really part of the beginning of this whole movement from volume-based to competency-based assessment. And so there are pros and cons to video-based assessment. It's very practical. You don't have to go to the OR and stand in the OR, and that's good for the patient because now everybody in the OR is focused on the patient and not training the surgeon and criticizing the surgeon. You can grab these videos and you can fast forward them, you can edit them, and that potentially gives you the ability to get anonymous reviewers, multiple reviewers. You can sit with the trainee while you're reviewing them. So lots of very practical advantages. But I would have guessed that, this is, for those of you streaming, I'm looking at a full room right now. There are probably 400 people in this room, and I'm gonna guess that very few of you have a system, a hospital system, that has scaled and uses video review routinely. It's hard to do this, to record these cases, store these cases, edit these cases. And if you don't edit them, it's very time constraining. We've also learned from a lot of the studies that I cited in the bottom of the slide that there can be a lot of bias from video review. If you compare an open case to a video case, the video cases have higher scores. Depends on the grader and how well you train the grader, and you may get different scores. If you edit the video, quote, too much, you may get higher scores. And none of these things that are not in the video are included in the assessment. How do you work with your team? How do you communicate? How's your decision making? How do you use your assistants, and how do you respond to verbal cues? And so let's talk a little bit about these competency assessment tools. First, you have to understand there are formative and summative. Formative are what we use a lot. These are for people in training. The summative are for people who are done with training and now you're trying to figure out where they are. And so before we use these tools, like you heard from our previous speaker, they have to be validated, they gotta be reliable, they have to correlate with patient outcomes, otherwise they're not very useful. And at this time, there are no studies of any successful implementation of long-term evaluation using a summative video assessment tool for a practicing surgeon. There are global assessment tools and procedure-specific tools, and many of you are familiar with the ones I've listed there. Those are usually global. And you can have a procedure-specific one, like a lap right colon assessment tool. They all have O's in their name, except for gears, and the O stands for objective. But they're not objective. You sit and use a 1 to 5 score, so I don't know why they're called objective. So here's what we have in colorectal. In 2013, a group in the UK said, well, they looked at the UK at the national level and they said, colorectal surgery is better for the patients if it's done minimally invasive, and there's not enough of this going on. How can we get more of this going on? And how can we do this safely? And so they used a Delphi method, and they created a CAT for laparoscopic colectomy, and they showed that it was reliable and had validity. And they basically would give the course, and the surgeons would do the course and be supervised and then take the test. And they showed, yeah, we can determine safe versus unsafe. This is a useful tool. They couldn't really determine nuances like expert versus common, but it also had very specific feedback, and thus people found it very useful. And this is what it looks like. There are 16 basically categories and different parts of the operation and different ways to assess, and you get scored 0 to 4. Well, so what about laparoscopic TME? We got lap colon now, what about lap TME? So this group in 2017 looked at all the literature and said, here's what a good lap TME tool would be, and let's see what's out there. And there was nothing good out there. And when they looked back at those trials, those lap TME trials, one of the things they noted is, none of those surgeons had been assessed to be in the trial. So who got to be in the trial? And were they all similar skill, or was there a lot of wide variability in their skill? And so a team came up with a lap TME tool, and they actually did it within 2 other trials. Within the a la carte trial and the 2D, 3D trial, they used a Delphi method, they got 62 experts, they created a scorecard or a CAT tool, they showed it was reliable and had consistency. And they actually showed that if you weren't in the bottom quartile, you had better path reports and better short-term outcomes. And if you were in the highest quartile score, you had the lowest morbidity, your patients had the lowest morbidity. This was actually the first study to correlate measured surgeon skill with rectal cancer outcomes. But it also showed that there was a lot of variation in surgeon skill in these trials. I mean, that's a pretty typical looking bell curve, and I think we'd all like to see it shifted a little bit to the right and maybe a little bit tighter. And they also showed, although this did not reach statistical significance, the local recurrence rates and the time to recurrence were best for the patients that were operated by the upper quartile surgeons. Again, didn't reach statistical significance, but certainly makes me think. So in 2018, we came up, well, actually 2017, we decided to do a robotic TME tool at Emory. And we presented this last year, and we did a similar process. We used the Delphi process to create a scorecard, and this is what it looked like. It had 14 questions. And we found that it had moderate and good inter-rater reliability on about half. And so this is something that we need to continue to work on if we want to use this in any meaningful way. So we have a lot of steps to go in our own institution, but we're working on it. Well, can we do anything else other than have lots of surgeons recording videos and editing videos and reviewing them? Yeah, maybe we can use computers, artificial intelligence. And I'm not an engineer, but basically you can use these CNNs, these convolutional neural networks, and you take a computer and you show it a couple of million frames of video and you say, this is a novice and this is an expert, and then you give it new video and say, classify these. And this study was done with the Jigsaw's data set, which is publicly available. That's the laparoscopic skill sets that all of our residents do. And they showed, with very high accuracy, that they could predict, just based on video, short segments of video, novice versus intermediate versus expert. And here's what it looks like. So you can see for suturing or needle passing, extremely high accuracy, extremely high F1 scores, which is what they use. And so if you're a novice, if there are 64 novices, they called 63 of you novices. And if there were 40 experts, they called 40 of you experts. So this computer was quite good at this. This is an area of what I'm particularly interested in, and it's called objective performance metrics. And it's during robotic surgery, and one of the original pioneers in this field is Andrew Hung from USC in urology. And if you look to the right of the screen, basically what you can use is, when you're doing robotic surgery, you have a surgeon and a patient, and there's a computer between the surgeon and the patient. And we can record all those little data movements, your wrist movements, your finger movements, the speed, the acceleration, your camera movements, your energy use, how often you use your non-dominant hand, your pedal use. We can record all of that. And so what a group at USC showed was, well, can you record during when a trainee's using the console and when an attending's using the console of different levels of expertise, and do these OPMs look different? Yes, they do. Can we correlate these with patient outcomes? Yes, we can, they showed. And can we come up with best practices? Yes, we can. And this is the way USC Urology does their anastomosis now, because when you use your right hand, forehand on this side, and your left hand, backhand on this stitch, they have shown urinary incontinence rates, length of stay, and sexual dysfunction rates were improved if you did it this way, those 12 stitches. And so we're the first group, we're trying to do this with proctectomy. And so we started recording cases in early 2020. We've recorded about 105 cases now, and we have data from 31 proctectomies. And I torture, for example, Dr. Schaefer pretty routinely by making her record her cases as well. And we've assigned tasks, and we presented this data at one of the other sessions here. So during a lower anterior resection, you have different tasks. And during the tasks, we can identify, is the attending surgeon operating? And you can see in the first step, there's a lot of activity. Or is the trainee operating? And you can see the second, third, and fourth steps, the trainee has really taken over the case. And we can look at things like speed and acceleration and wrist movement and finger clutching. And at this point, we have about 2.5 million data points from these 31 operations that we're starting to mine to try and mirror the work that was done in urology. And here's an example of where we're just describing an operation. We find that the mobilization of the left and the sigmoid colon is what we call a nodal step. And the whole left half of that Circos diagram is step 11, which is mobilization of the left and sigmoid, and there are many steps, different types of steps, depending on the surgeon and the pathology that can lead to that step, and there are many types of steps that can follow that step. We also have what we call convergent and divergent steps. And we're using this in our preliminary research to correlate with more traditional metrics, like how long did the whole operation take? How long was the console time of the operation? And so we're just starting to see how these OPMs can be valuable. So in conclusion, as far as laparoscopic TME, there are good assessment tools. They are typically being used in formative assessment for our trainees, but they are also available for summative assessment. But there is a lot of issue in the United States and in other countries in scaling these processes up because of time and money. We think we need an assessment tool for robotic TME, and you can't just take the lap TME or the open TME assessment tools because it's a different operation. We also think kinematic data, these OPMs, may be useful, and so we're investigating that. We think in order to achieve success over the next 5 to 10 years, machine learning or artificial intelligence will be helpful in scaling up these processes. Thank you very much.